I'm Dr. Gary Raskob, and I'm speaking to you today from the University of Oklahoma Health Sciences Center in Oklahoma City, Oklahoma. Today on Clot Chronicles, I'll be discussing the treatment of cancer-associated venous thromboembolism. The treatment of patients who develop venous thromboembolism in association with cancer is quite challenging for several reasons. First, these patients have an increased risk of recurrent thromboembolism and an increased risk of bleeding compared to similar patients with thrombosis who do not have cancer. But in addition, there are some patient and cancer-related factors that influence the approach to treatment. Now, historically, low molecular weight heparin, given for both initial treatment and continued as the long-term treatment, has been the approach of choice recommended by evidence-based practice guidelines. This practice dates back to the early 2000s with a landmark study which demonstrated that using low molecular weight heparin in this way was more effective than using just an initial course of low molecular weight heparin followed by oral anticoagulation with a vitamin K antagonist such as warfarin. Now, recently, with the advent of the direct oral anticoagulants over the last 10 years, the treatment of the cancer patient was a target to improve the quality of life and outcomes for these patients by potentially avoiding the need for these patients to inject themselves for many months. And over the last 3 years or so, we've had multiple clinical trials completed evaluating the direct oral anticoagulants in patients with cancer-associated venous thromboembolism. And recently, just this year, the NCN Guidelines revised their recommendations for the treatment of cancer-associated venous thromboembolism, such that now the direct oral anticoagulants are the preferred approach for patients with venous thromboembolism and cancer who do not have gastrointestinal cancer, and specifically who do not have significant intraluminal gastric or gastroesophageal tumors or other high-risk factors for bleeding. And so the direct oral anticoagulants provide an important advance for these patients without gastrointestinal cancer. It's clear that they're as effective with similar bleeding rates to the low molecular weight heparin regimens and can be therefore given and thus help patients to avoid the need for injecting themselves for many months. Now, among patients with gastroesophageal or gastric tumors, particularly intraluminal tumors, the direct oral anticoagulants either should not be used or used with caution because of an increased risk of bleeding in these patients. Nevertheless, fatal or very severe bleeding occurs similarly to low molecular weight heparin. Most of the excess bleeding is manageable with standard measures. But nevertheless, the increased risk of bleeding is a trade-off to be discussed with patients that is associated with the use of DOACs. And then in considering then other potential controversies and caveats about the use of the DOACs and anticoagulation in the cancer patient with venous thromboembolism, there are issues like the duration of treatment. It is generally accepted that treatment be given for a minimum of 6 months, but the optimal duration remains uncertain. Specific approaches with people with moderate renal impairment or other considerations, potential interactions with cancer drugs, and other issues like management in patients with thrombocytopenia or patients with brain metastases remain somewhat controversial in areas of ongoing investigation. We're pleased that we were able to bring together a group of experts in this field to summarize and discuss this area in a recent publication of The Oncologist that really highlights the evidence for the use of the direct oral anticoagulants. It gives the history of treatment of these types of patients and then outlines for clinicians some of those unresolved areas and the best guesses and suggestions of some experts who deal with these patients every day. And so we welcome you to read that publication and we welcome your feedback on that. This is Dr. Gary Raskob for Clot Chronicles, And I thank you for your attention.